tamponade and massive P especially. And then, I mean, a little less of a degree of these presentations would be urgent, like simple pneumothorax, and then depending on what it is doing at that point, and then asthma, pneumonia, pulmonary edema, COPD, metabolic acidosis, poisoning, valvular heart diseases, myocarditis, Guillain-Barré, and pulmonary embolism. And non-urgent would be your pleural effusion. Again, it depends on how much distress it is causing, if it needs to be drained right away. And yeah, neoplasm, any cancers and pneumonias. Right, so basically anybody who's coming in with, acute shortness of breath, usually this is our approach, like ABC approach, airway, breathing, and circulation, unless, as we discussed in the earlier slides, if the patient is bleeding catastrophically, then we know that the blood that has been lost needs to be replaced first before going to any other step. But otherwise, it's always ABC approach. Right. So, especially when we come to ABC, airway, breathing, and circulation, what are the easiest ways? I'm not we will of course look in the coming slides. What are we looking for particularly? But this approach should give us a good idea of how to approach a patient with acute shortness of breath. So the first thing is, look, listen, feel, as we all learn in medical school. So again, looking at the airway. So once we look at the airway, what do we see? Is there any foreign body, any fluid, any blood, or edema? So anything that is obstructing from within the outside. And if that's the case, then we will try to, take that obstruction away. Like, for example, if you see any fluid in the mouth or blood, you can suction it out. And if you see like a foreign body that you can remove, you can remove. Otherwise, you can call for help. But there's one top tip of disturbing the foreign body that you see. So you never do a finger sweep, just to check if something is there or not. Especially if it's at the at the end of the tongue, you might push it down. We don't want that. Basically, if something you can remove safely, you do it. Otherwise, you call for help. Again, listening to the airway. Of course, if it's noisy, then you know that there is definitely some sort of obstruction that's there. And we need to address that. If you're able to address it, fine. Otherwise, you call for help. If the patient is talking, that means the airway is good. So it might not be protected, but it's patent at the moment. So at that point of time, somebody's talking, there's airway would be patent, maybe not protected, depending on different scenarios. But mostly, if the patient is talking, then you can assume that this airway is okay. And then next is your breathing, and then what you're looking at breathing. In the patient is workup breathing, the respiratory rate. Again, looking, you can also see for clues that we've seen earlier. Is there any intercostal recessions that's happening, or how the patient is? Is there equal chest rise that you see on both sides? Is there an obvious wound or anything like that? And then breath sounds. Like you auscultate bilaterally to see if that's equal breath sounds, or if there are any abnormal breath sounds or no breath sounds at all. And then you check for oxygen saturation. And then next comes your circulation. Here, I've mentioned mental status. So, it's a good way of telling. Like, for example, if somebody obviously looks confused. So, a top reason could be he's getting decreased oxygen to the brain. So it's possible, or any decreased blood pressure, so basically decreased blood flow to the brain. So having a quick look at the mental status would be very beneficial. And of course, looking at the color as well. If they're cyanotic, blue or pale. And then feeling, of course, you feel all the peripheral pulses to see that it's got adequate circulation. And then the next one comes, checking. Of course, you connect to the monitor by the time, and then you see the heart rate and then heart rhythm as well, and the blood pressure. So this is our ABC approach. So I mean, anyway, like if you're with an acute shortness of breath patient, go with this approach. It's easier, and then address the problem that you have with each of them until you go to the next one. Oops, sorry. Right, and and then talking about the basic investigation. So these 4 investigations are readily available, I think, globally in majority of the emergency departments, I would say. A pulse oximetry, just to see the saturations, and arterial blood gas or venous blood gas, either ways. So arterial blood gas gives you a good view of what's happening inside the body at the metabolic level. Like, you get the pH and how much oxygen is there, and then how much carbon dioxide, if there is any dehydration, raised lactates and things like that. Easily done. In Oxford, in our ED, like, I mean, most of the times we do a VBG first, a venous blood gas. While you're gaining an IV access, just take a little bit of blood and then run a VBG. It gives you a quick idea. But let's say if somebody already has existing pulmonary problems, then I mean, it would be a good idea to do an ABG to get an accurate view of the body and the metabolic system. Right, and then chest X-ray. I mean, most of the EDs in the hospitals have chest X-rays as well, and then can show us multiple different pathologies. And ECG as well. It can show you arrhythmias and if the patient is tachycardic or not, and it gives you a lot of basic information. Right. Okay. Now we will discuss a few cases, and then especially around the acute shortness of breath. So this is a case of a 36-year-old female who's a known hypertensive and also depression on regular medications. So I mean, I think this lady she presented with shortness of breath and right-sided chest pain, which had been worsening from last night when she had presented to the ED. So basically, like about 5 to 6 hours ago. And so this was a right-sided chest pain, shortness of breath, and it was, the shortness of breath and the pain both were worsening with minimal activity. So this lady had a history of abdominal surgery for, a week ago for a small bowel obstruction. So now she's presented with shortness of breath. So initially on examination, I mean, she appeared slightly short of breath. She looked uncomfortable, and of course, running a physical exam, and also getting her vitals. So it's afebrile when we saw her. Sorry about the mistake. It was both the heart sound with S1 and S2. Both were heard, and it's slightly tachycardic, maintaining a normal blood pressure, and even the chest was clear to auscultation, the respiratory rate of 26, but she was requiring oxygen to maintain 96%. And soft abdomen, non-tender, and then no neurology. But when we examined her legs, I mean, we found that she had mild swelling on her left calf, which was, I mean, slightly tender, I would say, not, grossly tender at the moment. So basically just reviewing this case. So she's a third young female coming in with shortness of breath, history of surgery, and then also some, swelling to her left calf, slightly tachycardic, and then requiring oxygen. Amazing. Yeah, I see some from Abu Safia. Yeah, suspecting DVT or PE. Yeah. So we did an initial workup. So we have that in our mind, and then we just basic investigations and initial workup. So her bloods were normal, and renal function. Then ECG was showing sinus tachy. And the chest X-ray, nothing exciting on there, just some minimal basic electrolysis. Right. So agree. Yeah. 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 So CT, pulmonary angio, D-dimer, ABD. Yeah. Agree. So we're coming to that. And so initially, again, what is our diagnosis? That we're thinking. So definitely, I mean, as discussed, as Abu Sufyan mentioned, so it could be DVT or a P. Yeah, a P. And what further tests we should consider? I know you guys are already ahead in the in the game. Amazing. So the further tests that we consider again is CT pulmonary angio, D-dimer. All right. So we'll see how we come to those conclusions. Right. So this was a pulmonary embolism. Yes. Secondary to left lower limb DVT. So again, I mean, thinking about D-dimer, CTPA, VQ scan, and also the further investigations would be these ones. So now, what makes us decide we should do a D-dimer or a CTPA? Right. Okay. Yeah. I mean, yeah. That's. I mean, yeah. Thinking about, yeah, since she'd had a surgery. Yeah, I agree. But I mean, exactly. So as Madia says, well score is basically our decision point here. So basically now looking if we put this patient's data into this score, she has clinical signs and symptoms of DVT, so that gives us 3 points. Agree. And no alternative diagnosis at the moment, 3 points, and a heart rate, of course, more than 100. So and then immobilization or surgery in past 4 weeks. So she gets almost 9 points. So here, PEs are very likely diagnosis. So we skip the D-dimer and then directly go to CTPA, and that would give us, a clear diagnosis. And then the next things that we do is like, thinking about, providing, of course, providing oxygen and, anticoagulation. And then depending on the size of the PE and then how bad it's obstructing, then further specialty team will take over. And, again, it's a decision of either thrombolysis or, uh, interventional radiology will actually, suck that thrombus out. So the decision, those are further. So I mean, at least the first time when the patient comes to ED, at least we should be able to come until this point, and then the next step will definitely involve specialty. Right. So basically, I mean, understanding a little bit of pulmonary embolism. I know you guys know about this already, but we're just gonna go through it again. So basically, it's a blood clot in a pulmonary circulation. It's often from a systemic venous circulation that goes there, gets stuck, like, as you can see this from this cartoon picture. So blood cannot circulate well, and there's a lot of oxygen in the circulation blood. So, and then because of that, we have these classic presentation symptoms, like especially with hypoxemia that you can see, tachycardia, tachypnea, and sometimes chest pain. And this S1QT3T is not always classic, although, I mean, I've seen so many patients with PE without, the classic ECG signs, but a sinus tachy with, tachycardia is more likely for us to use. So these days we're also, I mean, more and more, using echocardiograph, I mean, 2D echo by the bedside. So especially, I mean, once you put the probe in, you can see that dilated RA/RB. So as you can see from this picture, if you compare it with the left side, it's quite dilated, and that can direct us about like basically aiding our into our decision making and diagnosis that this could be a PE. So and then treatment is oxygen supplementation, anticoagulation, and then thrombolysis. And of course, thrombolysis can be an ED decision, but if it's, especially if it's becoming a massive PE. So what do you mean by massive PE? Massive PE, I mean, we know that this is pulmonary embolism. CDP is done within how long of the patient presentation? So I would say as early as possible. So if you have like you've established a diagnosis, especially with so many clues that are being given to us, like history of surgery, chest pain, shortness of breath, and then tachycardia. We would say as soon as possible. Exactly. Yeah. Yeah. I'll I'll slidey. Sorry, my name reading skills are not great. Yeah, somebody who's unstable, or like especially if the patient is hypotensive and that this could be PE, then we call it massive PE, and we need immediate interventional pulmonology or interventional radiology to come and help us. It come with shock. Yeah, agree. Yeah, yeah. And if it's with a shock, then it's a massive PE. Agree. So right. Yeah. Any more questions? Is this clear? So basically, the idea is, I mean, a PE can present with acute shortness of breath, and this is a brief synopsis of that. Okay, we'll move to the next one. Right. So again, so this is a scenario I want you to think. Um, I mean, to be in this situation. So basically, let's imagine that you are a doctor. You receive you're working night shift. Let's say you receive a phone call from the paramedics, and they just call and tell you that they're bringing in a 33-year-old who's a known asthmatic, who's definitely having a clear established difficulty breathing. So this patient is brought in. You see the patient, and then you see that he's sitting upright, struggling to breathe, sweating profusely. And so basically, like, let's say you take him onto the bed, and you see that he's trying to take a deep breath in, and then heats his chest, and he loses his consciousness, and then now he's deteriorating, and he's not breathing anymore. So what are your priorities here? So right now, I mean, yeah, I mean, problem with breath sounds, I mean, not yet. We haven't, like put the stethoscope on there. He's just not breathing at the moment. So again, so I see that Dawood and El Masi have mentioned ABCD approach. I agree with this one. So first thing is, I mean, going back to our previous slides, our ABC is our priority. So he's not breathing, rest all is next. So airway, we need to make sure that his airway is patent and protected. So immediate priority would be to secure his airway. Right, and then coming to the second question that I put here, what has happened here? So he's a known asthmatic, and then it's a young male, and then known asthmatic, and then he's coming. Right, he's had an acute asthma exacerbation, right? An asthma attack, severe asthma attack. Right. Let's have a look. So as you guys have mentioned correctly, exactly. So what I would say here is, call for help would be our first thing. Of course, ABC, I'm not saying, that is the priority, but the first thing that comes out of your mouth is call for help. Call the appropriate people, a senior person that's around you, or an anesthetist who can, like, what if you're going for an endotracheal intubation, but you see that it's completely swollen, and then you don't know what to do next. So I think it would be a great idea to call for help, and then while the help is on the way, then you can start doing things. So yeah, definitely, securing an airway, definitive airway, especially with an ET. Yeah, I agree. Yeah, with the medication part, I mean, epinephrine and all the beta blockers and all those we're thinking. Yeah, of course. So medication part, definitely, I agree with you guys. So the first thing is, because he's not breathing at the moment and he's gone unconscious, that's the first thing we want to do. And then of course we're getting him to monitor, getting IV access and things like that, and then thinking about bronchodilators and steroids. My question is, why steroids? Do steroids help right away? Right, we'll come back to that one. And then magnesium sulfate is also a good bronchodilator that's being used more and more now. And so basically, this is the idea. Right. So steroids. So basically, you can use aminophylline. Of course, you can use as an IV form. But initially, what we would do is bronchodilate back-to-back nebulization with beta two agonists and antimuscarinics or anticholinergics. So especially with steroids, I mean they don't help right away. But let's say if the patient is to have another episode, it can decrease the severity of that episode. So that's why steroids are in place. Magnesium is also a good bronchodilator, but I mean, again, initially these are the ones, and then you go to that one. But let's say if the patient is not responding to bronchodilators, I mean, inhaled bronchodilators, then we can think about escalating to IV inhalant. So, right. So basically, the diagnosis for this gentleman was severe asthma attack. So because he's already known asthmatic. But thinking about further, so initially you have managed excellently. You've secured the airway. You've given him, medications. Now it's most the medicine part that kicks in. Is like trying to find out what might have caused it. There are multiple reasons. What do you guys think? What could have triggered it? Yeah, multiple. Yeah, infection, dust, panic, yeah, exercise, cold. There could be so many triggers that might have triggered it. So this is now, like once you've made sure the ABCs are all right, then you have time to think about what could have caused it. Right. So multiple causes. I've mentioned only a few causes, that especially are on top of our mind. Again, within this one, if it's anaphylaxis, then we're thinking about epinephrine. I think one of you mentioned epinephrine. So then we're thinking about if we should give epinephrine or adrenaline, and then addressing that, or infection, or multiple reasons. So yeah, so coming back to this one, so there could be multiple things, but especially as an emergency physician, or I mean, if you are encountered a patient with shortness of breath, those are the first things to do. And then once you know that the patient is stable, then you can think about, okay, what might have caused it, and then further, look into the details and then treat accordingly. Right. So talking about asthma briefly. So basically, asthma is nothing but reversible bronchoconstriction. And I mean, basically, I like to put things in very, very simple words. I mean, you can see that there. I try to use minimal technical words. So basically, air is blocked between the large airways to the alveoli, and then the alveoli might collapse as well. So the idea here is to open the airways, bronchodilate basically. And then the second thing that I've mentioned here is preventing stacking. So meaning, especially like, when if somebody has deteriorated, I mean, we, in the back of our mind, we want to oxygenate the patient. So let's say if we put a bag valve mask, and then we keep giving breaths and keep giving breaths, and then, but what happens is, as you can look in the picture, the air goes one way, but it's not able to come out easily. So just basically air gets stuck in there, and then it's not able to come out. So you have to keep that in mind. There were instances during my clinical practice where we could see that, chest is quite inflated, and then you have to manually compress the chest to bring the air out. And especially after you have ventilated, connected to the ventilator, you have to make sure that inspiration and expiration ratio is maintained. Meaning, if you're giving 1 second of inspiration, you have to allow about 3 to 4 seconds of expiration for the stuck air to come out. So that's what stacking means. You have to prevent stacking, and then give as much O2 as it's required for the patient. And again, steroids, so that the subsequent episodes are not as worse. Right. And then, yeah, I mean, talking a little more about asthma, I think I promised this will be the last slide about asthma. So it's assessment of severe asthma. So you can find more, very good guidelines on British Thoracic Society guidelines, which, segregates asthma in different categories. And then you can, go through these, and these will be really helpful for you to, have an idea of
what kind of asthma it is and what intervention is needed. And especially the last two are the ones that you want to look out for. With a PF of, especially in life-threatening asthma, if a peak expiratory flow rate is less than 92%, SATs less than 92, an oxygen concentration less than 8 kilopascals, and then a normal PCO2, an altered level of consciousness, exhaustion, and so on. And near fatal asthma is you have raised PCO2, and then this patient is requiring ventilation. So our patient that was mentioned in this case was in the near fatal category. Lucky for him that he was in the emergency department, and then we were immediately able to do what was required to keep him alive. Right. Okay. So coming to the next one. So this is a young male. So basically he was drinking in a pub, had a fight, and then he's, when we saw him, like he had bruises to his right and left chest, and then he said he had a stab injury. So somebody, took a how do you say, like the butter knife, and then stabbed his left chest, just below the left nipple. Basically, he was complaining of shortness of breath and pain at the stab site. Azam, I think you have the potential of being an emergency physician very soon. Right. So basically, he was. I mean, when we saw him, he was conscious, coherent, obeying, and then you can see his numbers. His good heart rate. Maintaining blood pressure. Everything was fine. He looked okay. But saying, just his short, complaining of shortness. Again, he's had a few drinks, smelling of alcohol, and then, so for us, I mean, to think about all these things, as a clinician, you should concentrate medically, like about what's going to happen, what's the worst that can happen in the emergency department. Right. So, so what could be, what are some possible potential complications? Let me go back a slide. So with this picture, so bruises and to both on his right and left, and a stab injury that the patient says what could be potential, right? Open pneumothorax, right? Right. Okay. Yeah. Left ventricular damage. Okay. Yeah. Haemothorax as well. Right. So there could be many possibilities. So, I mean, how I think about it is just imagine, like going back to the anatomy from the skin to the back, what are all the organs that are in between? There is skin, there's, pleura, and then, ribs, ribs, pleura, and then, lung tissue, heart tissue, great vessels, lymph, there's all the possibilities that can happen, especially like if there is a stab injury, like let's see, cardiac tamponade. Yeah, I think that's a good one as well. Yeah, so let's see, what are the, I've listed only a few as well, I think, but yeah. So pneumothorax, hemothorax, pericardial effusion, especially, or tamponade, or diaphragmatic injury as well. So I've seen only a couple of cases, in my emergency career experience, and especially with the lower and lateral stab injuries, you see a lot of diaphragmatic injuries as well, and then you have all the bowel contents going up into the thorax. So yeah, and then all these, so basically, I mean, I've mentioned only a few, but think about it, all the anatomy, from external to their great vessels, heart, all of those can get in between and then get injured. So our next steps here, again, are basically starting doing the ABC assessment. So we've done an airway assessment for this guy. This patient was talking and his trachea was central, and then there was no blood or mouth. And then breathing is good air entry. I mean, he has bilateral air entry, but there was decreased air entry on the left side. A respiratory rate of 26, maintaining saturations on room air. And then there is a 2-centimeter laceration on the left side. It was not bleeding at that point, and then there was no, air gushing out or anything visible, like a lung tissue or like ribs separated or anything like that. So coming to circulation, heart rate 100, blood pressure acceptable, 110/80, no other bleeding wounds, all peripheral pulses are present. So now we've completed ABC, and then you can go to D and E as well. But here, I mean, after ABC, what we did is like we wanted to, now we know that the patient is all right at the moment. So we are like, okay, we want to have a look at the wound, like if it's going deep or anything like that. So having probed into the wound, it appeared superficial. No active bleeding, again, no gushing out of air or anything like that. And then we gave him some analgesics and sent him for a chest x-ray. And guess what he comes back with? This. So he comes back with this chest x-ray. Okay. Now, yeah, of course, this is a pneumothorax. And then this has become tension now. Agree. Yeah, yeah. From yeah. So now if you look at the x-ray, what can you see? So, talking from so my approach to reading a chest X-ray is top to left. Sorry, top to bottom, right to left. I mean that should be our approach. Yeah, exactly. I see that Isra has mentioned tracheal deviation. So you see the trachea shifted to the right side. You have a collapsed lung on the left side, and then you see there are no bronchovascular markings. Right, right. The lung has completely shrunk, and then the mediastinum as well, this has slightly shifted to the left. So we know that this is a pneumothorax, but looking, so once he was back from the x-ray, he was more short of breath, and then his vitals were recorded right away. And he had a heart rate of 110. Now his BP starts decreasing, and then respiratory rate going up, and then, still maintaining SAT. So now this has become, probably it was a pneumothorax. Now he's become a tension pneumothorax because it's hemodynamically going down. So yeah, so basically the first thing is something has gotten in between. That's whatever has gotten in between has to come out. So whatever the fastest approach, right? So exactly, I see that Isra and Amjad have mentioned exactly. We need to decompress and then place a chest tube next, right? So now before I mean you guys are right. So before going that, now thinking about open and closed, open versus closed pneumothorax. So if it's an open pneumothorax, you know that air is gushing out, that there is a wound that's communicating from the atmosphere, I mean with the environment. Then you need to do something called as a three-way dressing, which is on the extreme right of the slide. So basically three-way dressing, not a gauze. So the idea is for the stuck air to come outside, and then the outside air to not go in. And this is, of course, a temporary measure. We need to put a chest drain. And then in our case, so it was not very clear that it's an open pneumothorax because no air was coming out at the moment. So maybe there was a communication that has probably sealed off. We didn't know. But anyways, so it's established that's a tension pneumothorax and it needs to come out. So we do a needle decompression in the second intercostal space, mid-clavicular line, and then followed by a chest drain. Right. It's clear until then. Yeah, decompression. Right. Right. And then chest drain. But sometimes why we have tension pneumothorax? We have an open wound. Yeah. So as we discussed, so maybe it's a possibility that this might not have been a possible open, because when we probed into the wound, it didn't seem like it was going through, or there was no evidence of, any air gushing out. So it was deemed to be superficial. So maybe we don't know, because he had bruises as well. So maybe there was, some other form of trauma. So maybe there was a rib fracture, so that might have caused it. So I mean, before we come to that, like sometimes even if there is a very small fracture, I mean, we cannot like exactly see it very clearly, or basically, have to do anything about it until there is like a flail segment. Right, agree. So from Madia, this question, is it true? So tension pneumothorax is a clinical diagnosis. So if you know that patients blood pressure is not optimal, not acceptable, and you know that there is no air entry, and then if he's going down, forget about X-ray. You get that air out first, and then next things are next. So yeah, that's how we approach it. So and sometimes even in emergencies, especially like sometimes in low resource environments, or and also if you don't have the equipment right away, uh, I mean, I know it might be not appropriate, or but you have to do, like, let's say sometimes you're not able to do a needle decompression or anything like that. Even just making a small incision and then putting your finger in, that's fine. We want the air to come out. So sometimes to save the patient, you might have to do certain things, and especially in very, very critical or like low resource environments, or that it's going to, the chest drain is going to be delayed. Just put an incision in the fifth intercostal space, um, in the safety triangle. This is something that you can look up after this lecture as well. Safety triangle under your armpit, and then um, once you know the landmarks, you can just put a small incision, and then put your finger in, and then get the air out, and then um, proceed for a chest drain until the help arrives. So this is something really important, I think, as a doctor, at least to know, to diagnose, and then to know what to be done. Right. So that was pneumothorax. Right. So basically, yeah, just briefly discussing about this one. So basically, I wrote in the most simple language. So it's basically stuff gets in between the inside of the chest wall and your lung, and air cannot circulate properly, blood cannot circulate properly. So basically, the idea is to remove whatever has come in between. Either it could be blood or air. If it's a hemothorax, it's going to be blood, and because that's collapsing the lung. So needle thoracocentesis, that's a temporary measure. Ultimate one is your chest drain. Right. So now let's say if you have chest drain, or like let's say if you have a pneumothorax and then the patient has collapsed, once you intubate the patient, it's possible that air might leak further and then worsen your pneumothorax. So I think that's also one of the one of the reasons why immediately after intubation you do a chest X-ray as well. It's not only to find the position of the tube, but also to see if there is any complication that has developed after the patient was intubated. Yeah, yeah, barotrauma, exactly. Yeah, barotrauma is also a possibility. Yeah, right. So that was pneumothorax, guys. Right. So I think the last case of the evening. So a 65-year-old male, sorry, female, presents with respiratory distress. So paramedics tell you that they couldn't get enough history from her, and then she was on the only meds that they found was furosemide, which is a diuretic. So when you see the patient is alert, can answer yes or no questions. She appears cool, clammy, and then a little sweaty. Temperatures are right, heart sounds are heard, and she's tachycardic at 130, and then a blood pressure of 220. And then when you auscultate, you hear bilateral crepitations, which are quite extensive, both sides. Um, Tachypneic at 28, and oxygen sats 93% on high flow oxygen. So this is 15 liters with a high flow mask. And she's got bilateral pedal edema. Right. So now just thinking about this, what are we thinking? Yeah. Pulmonary edema, heart failure, acute pulmonary edema, exactly. So so initially, I think, this X-ray is not for this patient, but I've just put it for our study purpose. So if you can see in the X-rays, like quite a lot of bat wing appearance. The fluid basically has gotten into the lungs. Um, and this is possibly due to the heart failure, acute pulmonary edema, because she was, we have no history. We only know that she's on furosemide, which is again quite a common medication in heart failure, where you want to make sure that there is no fluid that's building up. Right. So, and then on the ABG, we saw that this was this hypoxemia, and then ECG was showing sinus tachycardia. So, why do you think the blood pressure is so high? So basically, I mean, because the ability of the heart to pump is negligible. I mean, it's not working properly. So there's so much pressure that's building up in the vasculature, and it's the heart failure that's leading to this one. And then the heart is trying really hard to pump the blood. Therefore, I mean, you see that there's tachycardia. But while that's happening, the oxygen demand for the heart increases so much that they turn hypoxemic. Right. So coming to the basic problem. So the heart stretches so far that it cannot contract well. So this is going down on the Frank-Starling curve. And then the cardiac oxygen demand increases, and then because there is so much pressure and the blood is not circulating properly, what happens is if you go back to your physiology, the hydrostatic pressure and the oncotic pressure balance is disrupted, and then just fluid just seeps into the alveoli. And then the surfactant that's sitting there trying to keep them open gets diluted, and then it won't be able to keep the alveoli alive so much, or recruited so much. So basically, I mean, the bottom line would be it's a derangement of cardiac and vascular arrangement of the body. So it's a vicious cycle. What do you do? So this is what we do. What we do is, I mean, the first approach, or one of the approaches, I would say, would be to increase airway pressure. You give you put an IV, non-invasive ventilation, so that you're giving air or oxygen with more pressure, so that you're trying to push off the fluid away from the alveoli, and then also helping the body or the lungs give more and more oxygen. Or ultimately, like if non-invasive ventilation is not working, then you're thinking about intubation. Yeah, oxygen, of course. So the first thing would be the oxygen. But if it's not working, if it's just because our patient was 93% on 15 liters of oxygen, so you want at least 90 or above 94%. So you're thinking about non-invasive ventilation. If it's not working with that, then you go to escalate to intubation, and then dilate the blood vessels. So basically, there's so much pressure, and then you just give nitroglycerin or GTN, either by puffs, or I mean, usually, especially in the patients who present to the hospital, and that this is acute pulmonary edema, you basically give them an infusion of nitroglycerin, so that their blood vessels are dilated, which will help with the blood pressure and also take the load off the lungs. Next would be, you have all this excess. Yeah, applying Foley's catheter. Yeah, why not? You can apply that, and then you can also monitor input output, and then agree. If the patient is, like, let's say, awake, and if you're is able to is able to urinate, and then if you can collect in a pot, I wouldn't aggressively run to that. But let's say if the patient is requiring intubation, if you're sedating the patient, then definitely Foley's. And then the third approach would be getting excess fluid out, again by diuretics, furosemide, if the kidneys are working. But sometimes you have that you have heart failure patients along with kidney failure as well. Then you're thinking about dialysis. And then increase the contractility of the heart. Sorry, it's my bad. It's not dopamine. It's dobutamine. We give incremental doses of dobutamine infusion, again, to help increase the contractility of the heart. Right. I think, yeah, this was heart failure. Right. She has hypertension. Right. So now here, because we know that she's established heart failure, NTG, nitroglycerin, right now would be our best option first. So this should also bring her pressure down. So that's what I would say. Otherwise, because her heart pumping effect has decreased. I'm just talking in simple words. So giving, let's say, labetalol, a beta blocker, would further, decrease the work of heart. We want her heart to contract more and more. Hydralazine, yeah, why not? Why not? I mean, there is uh, no absolute no to these options of medications, but NTG would be a good choice. Initial um, what's it? I think you can start with nitroglycerin because nitroglycerin is, or you said, a lot of hospitals around the world also use nitroprusside. I think in the US they would prefer nitroprusside over nitroglycerin. So again, depends on what your trust policies are, and then what um, the departmental policies, like what drug they're using most commonly. But you would never be questioned or like asked for any clarification if you're using NTG. And then you can also discuss with your cardiologist about what's the best drug, and what they have a department of protocols of what they use. Majority of our patients would be trauma patients. Sometimes, very rarely. I mean, like I've never seen somebody, but if you're thinking about any aneurysmal rupture, I mean, it's very unlikely that like if they would survive for very long. Uh, but that's something to keep in mind. But yeah, majority of them, 99%, would be trauma. Right. Thank you very much. Thank you very much. You
Thank
all
you
were
very much.
great. Yeah, and then
It
you
was
asked very
amazing,
good questions.
interactive,
Yeah,
and very informative. Thank you.
of course, of course. All right.
All right.
Have a good evening, and then see you next month. Yeah.
Yes. See you next time.
Okay. Bye bye.
Goodbye, everyone.
Bye.